This presentation will cover giving birth. As a definition, a normal labor is the process of moving the fetus, placenta, and membranes out of the uterus and through the birth canal. There are different stages and phases of labor that we have to know about. Stage 1 is where the cervix dilates from 0 to 10, which is full dilation. And this is the stage where there are 3 phases within it. It's the only stage that's broken up into 3 phases. So in stage 1, where you're going from 0 to 10, there's the early phase. That's when the cervix is opening or dilating from 0 to 3 centimeters. And that takes around 8 to 12 hours, depending on the patient. And contractions are usually 30 to 45 seconds long, and they can be in between 5 and 30 minutes per in frequency. The active phase can last 3 to 5 hours, and it's when the cervix is going from 4 to 7 centimeters. And generally, the contractions are 3 to 5 minutes apart, and they tend to last 45 to 60 seconds. Then you have the transition phase. And anybody who's walked down a maternity ward, especially in the old days before epidurals, you could absolutely know which women in which room was in the transition phase. This is a very uncomfortable phase of stage 1. It's the final part where the cervix then has to dilate fully up to 10 centimeters. And at this point, the contractions are lasting longer. They're 60 to 90 seconds long, and they're coming anywhere from 30 seconds to 2 minutes apart. This phase tends to last anywhere from half an hour to 2 hours. Thankfully not long, because it is quite difficult. Then we have stage 2. That is from the point when the cervix is fully dilated to 10 centimeters up to the birth. And this part is usually a couple of hours as well. Stage 3 is when the birth of the baby happens in between that point and the delivery of the placenta. And this can take anywhere from 5 minutes to up to an hour. Stage 4 are the first hours following birth. This is a diagram that midwives like to use, and it's a nice one. It gives families, patients, kind of a visual on what's going on in the stages of labor and how long each can take. For instance, early labor can take hours to days, and just like I said, the contractions are mild. They last 30 to 45 seconds. They occur every 5 to 20 minutes, and they're irregular. And again, this is where the cervix is dilating from 0 to 3 centimeters, and the woman is typically at home trying to get some rest, maybe eating and drinking, resting when they can. Walking can help. But anyway, this is a diagram that's kind of a nice picture that guides you all the way through the stages. Typically, midwives will have something, just FYI, called the 4-1-1 rule. And they like to tell patients, come in for evaluation if the contractions are 4 minutes apart, they last 1 minute, and this happens for at least 1 hour. So 4-1-1. The physiological effects of the birth process, of course, are complex. We're going to look at the mom first and the maternal response. So labor contractions are, of course, intermittent, which is important. Mom needs to rest, and the body needs to rest, and there needs to be time to allow the placental blood flow to normalize and to exchange oxygen and nutrients and take out waste products between contractions. The upper uterus contracts really actively during labor, and it does that. It starts at the top, these contractions, because it's making use of the concept of gravity, and it's easier to push downward as opposed to upward. So the uterus contracts actively and pushes the fetus down. These actions will help to bring about cervical effacement, which is the thinning of the cervix, and dilation, which of course is the um, opening of the cervix. Uh, You'll see some diagrams later, but the uterus is pretty remarkable in that, again, the contractions start at the top, or the apex, or the fundus of the uterus, and the contraction spreads throughout the uterus. It goes downward, and that is to help, spread that force, that contraction, and push the baby down. Labor contractions themselves are, coordinated. They become very regular in pattern with increased frequency, duration, intensity. They are involuntary. Walking can help to stimulate them, and anxiety and stress can help to slow labor down, which is not good. But basically, once you're in labor, you can't just will it to stop. So it's an involuntary process. And contractions are intermittent, again, for that very important reason, to allow the body to rest and for the neonate in the uterus to get all the oxygen and nutrients it needs. This is a diagram of uterine contractions. Each contraction has these distinct time periods, or phases we call them. There is the first phase, an increment phase. As you can see, the contraction is strengthening, it's ramping up in intensity, and it reaches its full intensity at the peak, we call it. That's when the contraction is the most intense. And then the uterus begins to relax, and we call that phase the decrement. And so this diagram is showing you those three phases, and it's also showing you that the contraction duration begins at the start of the increment and ends at the end of the decrement, that the interval between contractions is between the decrement, the end of one contraction, and the increment, the start of the next contraction, so that period in between. And then the frequency, which would be the beginning of the increment of one contraction to the beginning, the increment of the second contraction. The uterus, as I mentioned, experiences contractions that start at the fundus or the top and then spread downwards through the uterus. The upper 2/3 of the uterus is very actively contracting, while the lower third and the cervix are just passive. The net effect of labor contractions is enhanced because that downward push from the upper uterus is accompanied by a decreased resistance in the lower uterus. The upper uterus muscle becomes thicker during labor, which is an interesting phenomenon. So it actually builds, it becomes thicker, while the lower third, the cervix and the lower third, actually become thinner, so that the entire shape of the uterine cavity will become thinner and more elongated to kind of straighten out the baby and direct it downward appropriately into the pelvic area. So this diagram is kind of showing you what the abdomen might look like before a contraction and then during a contraction. Contraction cycle and pattern are described in terms, as we mentioned before, of frequency, which, recall, was the beginning of one contraction to the beginning of another. You might hear somebody say, oh, my contractions are 3 minutes apart. Okay, they're talking about that frequency. We also describe the pattern of duration. So that's the length of each contraction from beginning to the end in seconds. So we might say her contractions last 55 to 60 seconds. We also look at intensity. That's the strength of the contraction. And we label the strength mild, moderate, or strong. And this is palpated by the nurse, because if you ask the patient, they'll probably think they're all extra strong. But this is something that takes practice. When you get to be a new nurse in the OB unit, you will have a preceptor orienting you if you're new to that area. And for a good way of training the new nurse is to, for the experienced nurse to feel a contraction and then say, okay, now you feel and tell me what you think it is. And through that process, you begin to learn what mild, moderate, or strong actually feels like when you palpate the fundus as the nurse. And then the interval. As I mentioned, that's the period between the end of one contraction and the start of the next one. And that's what this diagram is showing you. So cervical dilation and effacement, again, effacement is the thinning and the shortening of the cervix, and we measure that as a percentage. So 0% effaced would be not at all thinned or shortened versus 100% effaced. So that's a perfectly thin, ready to go cervix. So thinned and shortened in preparation for the birth. Dilation is that opening in centimeters, and this diagram is kind of showing you what that might look like and the differences in the prima gravida and the multigravida between before labor and then effacement and dilation, the stages through which we go through. Next, we have to look at the fetal response. So in early labor, the baby, the fetus, actually begins to slow down its fluid production in the lungs. This happens more and more as the baby gets to term. And this fluid gets reabsorbed into the lung tissue, and it's very important so that the baby can breathe extrauterine. The thoracic pressure that occurs to the baby as it's being squeezed through the vaginal canal, as it's being born, helps to expel into surrounding tissues any remaining fluid that didn't get absorbed in the late term or during the labor itself. Now you can imagine that a baby born by C-section would not have the benefit of that thoracic compression, and if the baby is born early, has not yet entered that phase where fluid production is decreasing. And so for those couple of reasons, the babies born by a C-section are at higher risk and need a closer observation of their respiratory status. We like to say that there are 4 P's to the birthing process, 4 components. And these consist of powers, and those are uterine contractions and mom pushing. There's passage, and these are those natural mechanisms of labor that is going to favor an efficient passage of the fetus through the mother's pelvis, such as her pelvic shape. There's the passenger itself, that's the fetus, but also that's the membranes and the placenta. The presentation and the position of the fetus is described in relation to the maternal pelvis. And then there's psyche, or the maternal state of mind, and we'll look at each of these closer. So starting with powers, the 2 powers of labor are uterine contractions, which of course are involuntary, and then maternal pushing efforts, which are voluntary. And so during the first phase of labor, from the onset to all the way through full dilation, the uterine contractions are the primary force that are going to move that fetus through to the maternal pelvis. During the second stage of labor, when we have full dilation, effacement, and we're ready to expel the fetus, this is when the mom has to use her voluntary pushing efforts to propel the baby all the way out. Looking at passage, so the passage for birth for the baby consists of the mom's pelvis and soft tissues that either help or hinder the baby sliding through. The bony pelvis is very important to the outcome of labor. If you don't have the right shape or size, you're going to have a have a difficult labor or what we call dystocia. The softening of the cartilage that links the pelvic bones starts to become more relaxed and softened as we get closer to term. A hormone named relaxin is secreted, and it helps there to be a little bit more play or movement amongst those bony parts. This is a diagram of the pelvic proportions, and you can see that there are different diameters between different anatomical aspects of the pelvis. So if you look at, for instance, the very top middle pelvis, if you're looking from above straight on through the pelvis, you can see that the diameter between the sacrum and the symphysis pubis is 11.5 basically centimeters, and the transverse diameter between the two outer side edges of the internal opening of the pelvis is 13.5 centimeters. And of course that's optimal. This would be kind of the perfect pelvis. These particular bony prominences are very important to know as a nurse. When we do vaginal exams, we have to reach up into the vagina and feel where the ischial spines are, because we want to know where the presenting part, which is usually the head of the fetus, but we want to know how far above or below that presenting part is in relation to ischial spines, and that's called its station, which we'll get to. The passenger is the fetus, but also the membranes and the placenta. And of course, it is a significant factor in the process. The fetal head in particular is the largest part, and so its diameters are very important. We've got to make sure that its diameters are smaller than mom's pelvic outlet diameters. Then there's fetal lie, and what this is the orientation of the fetus, its long axis compared to the woman's long axis. You'll see pictures shortly. Attitude means the fetal body parts in relation to each other. A normal attitude is when the chin is flexed to the chest. Presentation means what is the presenting part, or the first part that you feel that's entered the pelvis for birth. Which part is presenting, or do you feel? So cephalic is normal, so that's the head, but breech can be born vaginally sometimes, but breech is anything other than cephalic. So you might have a footling breech where you have a foot poking out, and we'll look at that closer. But the baby's position is also important within the womb. The most common and favorable position for the baby is left occiput anterior, by the way. So looking at the fetal head, very importantly, babies have those overriding, or the ability to override, bones of the skull. And through compression through the vaginal canal, those bony plates can override each other and make the dimension a little bit smaller. But you can see, remember I showed you that one diameter of the mom's pelvis was 13.5 centimeters, and the other diameter was 11.5. And so you can see that the baby, it's a tight fit, a very tight fit. If you look exactly across the forehead, the occipital frontal diameter, that's 11 centimeters. If you have a baby being born whose chin is not tucked into its chest, then that supraoccipitamental diameter is 13.5 centimeters. So that's going to be a real tough one there. More dimensions. Okay, I said we'd look a little bit more at lie. And remember, this is the orientation of the fetus's long axis to the mom's long axis. And what you see here in A is the normal, the longitudinal lie. So 99% of the time, this is what we have. The baby's long axis is oriented same direction as mom's. Sometimes, though, you might have a transverse lie. And so this happens in 1% or a little bit less, somewhere in there. Sometimes you might have what's called an oblique lie. So oblique is, diagonal. So it's in between longitudinal and transverse. I mentioned attitude is the relation of the fetal body parts to each other, and that flexed is best. So baby A is in a normal position, flexed, chin to chest, extremities folded in, tight little package. That's going to be easier to pass. Baby B is in extension, and that's a bad attitude. It's going to be much more difficult on mom and babe because we have a more larger diameters that have to be passed. So I mentioned before station, and that when we do vaginal exams on the laboring mom, part of what we are determining is where that presenting part of the fetus lies in relation to the mom's pelvis. And we feel for the ischial spines with our fingers on either side of the pelvis, and then estimate how many centimeters above or below the ischial spine we can feel that presenting part. So, for instance, when we say that the baby's in cephalic position, presenting part is -1 station, you can see by this diagram that the baby's head would be, in this case, the head, but the presenting part is 1 centimeter above, closer to the cervix, that is, the mom. If the baby is +1 station, the presenting part, in this case the head, is 1 centimeter closer to mom's vaginal opening, so that direction. In this particular diagram, the presenting part is at 0, so it is perfectly even aligned with the ischial spines. Next, looking at presentation, looking from the porthole. Presentation is the fetal part entering the pelvis first. So that's its presenting part. And we hope it to be the head or a cephalic presentation. But there are other possibilities. So there are 3 categories. There's cephalic, which is normal. There is breech, or there's shoulder. Breech and shoulder are going to definitely lead to prolonged labor and most likely a C-section. If you look at these diagrams, you see vertex presentation is complete flexion, and when you look at the pelvic cutaway below, we have the most wiggle room to pass that baby through. So that's the best presentation and vertex, and that's most desirable. Next, we have military presentation. If the baby stays with its chin untucked and it's only mildly flexed, as in this diagram, we have a tighter fit, but still possible. And actually, through the process of labor, the head might, and very commonly does, become flexed with chin to chest just through the process of the squeezing. So it doesn't, sometimes those military presentations correct themselves a little bit. Brow presentation is going to be a tough one. The baby's not flexed very much at all. And again, when you look at the cutaway, you see that it will fit, but it's a tight one. And then full extension is a very bad presentation. We've got face first, and that's the very large diameter to pass through the birth canal. These are just more of those dimensions. You can see why vertex is optimal because baby's head is probably 9.5 by 9.25 or somewhere in there. Can fit through. The siniciput presentation where the baby's head is not flexed has pretty large diameters there. And in C, where we have the brow or the face presentation, the baby is in full extension, and that's going to be a very difficult pass through. These are some variations of a breech presentation. So breech presentation typically means either butt or feet first as the presenting part, and this occurs about 3% of the time in pregnancies. So a frank breech, as you can see, the baby is all folded up, butt first, legs all the way up to its head, and that's going to be quite a large diameter when the pushing gets to the part where the shoulders and legs and head are trying to enter the vaginal canal and go through the pelvic inlet at the same time. The full breech, as you can see, is also butt first, but the baby's folded up a little more. Again, a very large diameter to fit. And then you have footling breech. There can also be shoulder presentations or shoulder breech. And so the problems again with these, in the first case, the butt, it's smooth, but it's not firm. And so part of the work of a contraction, by pushing that hard head down against the cervix, it helps create cervical dilation and effacement. And so a laboring mom with a breech presentation fetus doesn't have the benefits of a hard head kind of being pushed or forced with each contraction against the cervix to help the cervix efface and dilate. Also, the head is the last thing delivered, and so this is going to increase the chance for a cord compression between the fetus and the mom's pelvis. And then also, because of the potential for cord compression, you have to really deliver the head very quickly, and so there's not any time for molding, which is the term when the baby's head skull bones override each other to create a smaller dimension when the sutures overlap. If the head has to be delivered very quickly in order to avoid a compressed cord, then there's not time for that molding to occur. Okay, so this is a diagram to help us study position. So fetal position again describes the location of a fixed point of the presenting part in relation to the mom's pelvis. So if you are right or left, then that's the fetal presenting part, again, hopefully the head, but the fetal presenting part in the right or left of the pelvis. And then we have occiput, mentum, or sacrum. So then that's the presenting part that you see. Is it the occiput or the skull presenting? Is it the mentum or the chin? Or is it the sacrum that's in that position? And then we look at anterior, posterior, or transverse. So then how is that presenting part positioned in the pelvis? So if the fetal occiput is located in the left anterior quadrant, then the left occiput anterior is what we would describe that as, and that's LOA. LOA, left occiput anterior. As example, if the fetal sacrum is presenting and it's in the mom's right posterior pelvis, then we would call that RSP, right sacrum posterior. Okay. So spend a little time looking at that so you know right or left where the presenting part is sitting. Then is it occiput, mentum, or sacrum that's presenting? And then is it anterior, posterior, or transverse? These are some diagrams that would show you, for instance, left occiput anterior or right occiput anterior. So you can see there that the head, or the occiput of the head, is presenting and it's engaged in the pelvis, and it is in the left occiput anterior if you're looking at the diagram at the very top of this left hand slide. So spend some time acquainting yourself with those terms. So next we need to look at the other power called psyche, and just like it says, it's the state of the mother's mind or her psyche, which is a crucial aspect of childbirth. When the woman has anxiety or fear or fatigue, she's going to perceive more pain. She's going to have a lessened ability to cope with the pain and maybe just be too tired for all of this. Anxiety can lead to severe contractions of the pelvic floor and the perineal muscles, and that's going to impede natural labor progression. Fear and anxiety are known to thwart normal progress in labor, so we try to avoid that, and we'll talk more about that in your chapter on pain management in childbirth. What happens is the mom's catecholamines are secreted, and it stimulates a fight or flight response, and that situation inhibits uterine contractions. It makes them uncoordinated and less effective, and it also reduces the placental blood flow, which is going to be harmful for the baby. It can cause the baby's waste products to not be eliminated, for not enough oxygen to come in, and when that situation happens, the baby can become metabolically acidotic. Relaxation just helps to augment the whole natural process of labor and make everything work better and go smoother. Cultural values play a part in all of this, and culture to culture, whether you're allowed to scream loudly with pain or whether you're supposed to be stoic, all those things are kind of acquired by us as we grow up. It's important for a nurse to help us know what's going on with the patient culturally, and to help care for the woman in a way that's culturally sensitive and meets her needs. For you may know that language, we have to get interpreters if the woman speaks a different language than us, and needs to have her needs known, and we need to communicate. At the hospital locally, you can use the ASCOM phones and dial in for all kinds of different language translators. But does she also have issues with touch? There are some cultures where, for instance, a woman shouldn't be attended to by a male, or maybe she has been a sexual assault victim in the past, and so she doesn't like to be touched. Who is the decision maker in the family? There are some cultures and religions for which, even though the woman is the client and she's the one having the baby, she's not the one you ask any questions about it to. Who is the primary support person? Are there specific practices that they would like to implement? Because this is such a life-changing event, it's important to take a holistic view and try and incorporate all those aspects so that we can make the most beautiful and meaningful event for the family that we can. So, premonitory signs of labor are those indications that labor is getting close. They're like little warning signs. And Braxton Hicks contractions are some of those warning signs. Those are like little practice contractions. They're not regular. They are felt more in the abdomen as opposed to the lower uterus. They are uncomfortable, but they're not as bad as the real thing. So I like to call them just little practice contractions. They do, as labor progresses, become a little more regular and a little more painful. But again, they're not the real thing. Lightning is the term for when the fetus drops down into the pelvis 2 to 3 weeks before birth. So the baby sits at the highest point in the uterus, and you can feel the fundus, the highest point in the woman's abdomen, at about 36 weeks. And then after the baby drops down, or what we call lightning. There's an increase in clear, non-irritating vaginal secretions. Part of this is because the fetal pressure will cause a congestion of the vaginal mucosa, and that's important because the lubrication is going to assist the whole process. You may have bloody show. That is a mixture of thick mucus and blood, and as the cervix starts softening, dilating, and effacing, that will that plug that stopped the flow of bacteria up through the vaginal canal gets loosened. A lot of women experience an energy spurt. Some people call it nesting. That's an early sign that we're getting close to labor, a little burst of energy to fix the nursery or to handle a remodel. That comes when it's pretty close time to labor. Also, the women will experience actually a small weight loss, about 1 to 3 pounds. That's from the change in estrogen levels. They lead to increased fluid excretion. We actually don't know scientifically, all the causes that come together to make labor start. We know that it starts when the factors that prevent pregnancy or prevent birth are overcome by the factors that favor birth. And so here's an example. So one of the things that changes is the ratio of estrogen to progesterone. Remember that progesterone is the hormone that keeps you pregnant. So when that starts to decrease and estrogen increases, that can trigger the onset of labor. Oxytocin increase occurs when labor begins, and that helps to support the process. Pressure from the large fetus as it is inside the uterus and is as it has dropped and sits down in lower into the pelvis after lightning, that irritates the uterus and the cervix. And so those are just some of the processes that we know kickstart labor. But like I said, we're not fully sure what all the dynamics are physiologically. The best thing we can say is when, like I mentioned, when the processes that favor labor increase over the processes that don't favor labor. It's important to know the difference between true labor and false labor because there is a difference. Some women, however, everyone's unique, don't have symptoms that are typical of true labor. And so we have to look at, the bigger picture. But if a woman is ever uncertain, they should be evaluated because we certainly wouldn't want to miss and have her birth at home unattended. Typically, false labor, some signs of false labor would be that her contractions are inconsistent. Because in true labor, contractions become consistent. In false labor, activity has no bearing on your contractions. Doesn't make it better, doesn't make it worse. Whereas in true labor, walking can help stimulate contractions. In false labor, the pain, as I mentioned, is usually in the abdomen, maybe a little bit in the groin. But in true labor, pain, it tends to be in the lower back and it wraps around the very low abdomen. In false labor, there is no change to the cervix, whereas in true labor, there should be a progressive dilation and effacement. Typically, before you look at this question, I will say that typically some advice about when to go to the hospital are this. If your contractions are increasing in frequency, duration, and intensity, if you have ruptured membranes, because any gush of fluid needs to be evaluated, or if you see bleeding. Also, if you notice a decrease in the fetal movements, so You used to feel the baby kick 10 times an hour and now nothing? Or anything else that's concerning? Okay, a question. Oops, I went too fast, but the question was, a pregnant woman is at 38 weeks of gestation. She wants to know if any signs indicate labor is closer to starting. The nurse informs the woman that which sign of labor may begin soon. Was it weight gain of 1.5 to 2 kilos? Was it increased in fundal height, urinary retention, or surge of energy? It's D, surge of energy. A is wrong because they don't gain weight. As I mentioned, women, because of the change of estrogen levels, they actually lose a little bit of weight. The fundal height does not increase. As I mentioned, it's the highest at about 36 weeks, and then lightening occurs and the baby drops down into the pelvis. And it's not urinary retention. In fact, the woman begins to avoid some of that extra fluid, that weight gain, partly due to the increased estrogen. Okay, now looking at mechanisms of labor. So, one of the mechanisms is the descent of the presenting part, the engagement of the presenting part, and that's at its widest diameter when it reaches the level of the ischial spines, which is station, remember. The amount of flexion of the fetal head, we hope that it's flexed down so that the smallest diameter can pass through. Then there's an internal rotation, and this allows the largest diameter to match the pelvis's largest diameter. Then there's extension of the fetal head as it passes out through the symphysis pubis. Then there is external rotation. This allows the shoulder to rotate internally to fit the pelvis. And then finally, there's expulsion of the fetal shoulders in the body. So all of these things are the fetal position changes that help to adapt size and shape of that fetus to that of the mom's pelvis so that baby can come out. Okay. The upper left hand of the slide is indicating those processes for descent. The upper right hand of the slide is showing internal rotation. And then the other ones are explained pretty much. The middle right hand of the slide shows external rotation, and the lower slide shows expulsion. So going back to the stages of labor, remember that the first stage of labor was broken up into 3 phases. The early phase, or sometimes called latent, active, and transition phase. So looking at the early phase, that was the point at which the cervix goes from 0 to 3 centimeters. The contractions start to become more irregular. The frequency is every 5 to 20 minutes, so mom can rest. They don't last very long, 30 to 45 seconds. And when the nurse palpates the strength of contraction, he or she would describe it as mild. So remember that cervical effacement and dilation is what's occurring in the first stage, and that the stage starts with the onset of true labor contractions, and it ends when you've gotten to 100% effacement and full 10 centimeters dilation. The first stage is the longest for both primips and multips, and it's considered a time to kind of rest, to get your stuff together, your head together, have a little nourishment or hydration. You just need to prepare for knowing that the main event is ahead. Next in the first stage of labor is the active phase, where the cervix starts at 4 centimeters, 3 to 4 centimeters, and goes up to 7. Okay. So the contraction pattern becomes more frequent, the duration is longer, the intensity is now moderate to strong rather than mild. And during this phase, for primips, the progression is about 1.2 centimeters per hour, whereas for the multip, that uterus has been through this before. It's not a rookie anymore. It's primed. It knows how to do this job because it's done it once before, and the process is faster. So about 1.5 centimeters progression for the multip. The discomfort is going to increase as the pace of labor increases, and the fetus has to internally rotate as it descends down into the pelvis so that it is hopefully in an OA position. During the active phase, the woman may be restless, serious, or intense. She may have cold feet, but also her head may feel hot, so it's not uncommon to have to put, socks on the feet, but have a fan by the face. She may have a dry mouth. Part of this could be from fight or flight, but also she might be starting to mouth breathe. Her self-confidence wavers because it's getting real now, and it's hard and it's hurting, and she may be very tired. She has an increased dependency. I mean, you can't do much but just be in labor. So you're dependent on others to, bring you sustenance, to help you achieve pain control, to help you guide your thinking, that kind of thing. Now the transition phase, that begins at 8 centimeters and it ends with full dilation. This is the hard phase. This is, as I mentioned, when in the old days before epidurals, you would hear screaming down the maternity ward, and you would know exactly who was in transition. So the contractions are more frequent, they last longer, and they are strong by palpation. During this time period, the woman may have a very strong urge to push if the presenting part is at a low station. She may feel backache. Again, that could be from the contraction, pushing that hard head against the sacrum. She may have nausea and vomiting. That's just a kind of a common response to pain some people have. She may have trembling limbs. All the blood flow, all the action is at the core of the body. So, legs are trembling. There may be increased blood drainage from the vagina. We as nurses need to check on I&O. There may be a need to feel like you have to void frequently. That's because of the heavy presence of the fetus pressing against the bladder. If the woman has an epidural in place, there will be a Foley catheter inserted because she has no sensation down there. And so if she has an epidural, then this might not come into play because she'll have a catheter in. The woman is typically agitated and irritable. This is the time when you might hear some women scream for their husband to get away from them, and it's their fault they're in this position. They may become discouraged and tired, and that doesn't help their coping ability. So relaxation at this point is pretty much impossible because you're actively in discomfort and your body is doing its thing to push this baby out. The second stage of labor begins when that full dilation has been achieved in the first stage. So 10 centimeters to birth is this time period, and pressure on the rectum and the pelvis floor causes an urge to push. Mom's pushing efforts help to augment those involuntary muscle contractions, and she may complain as the baby's head is crowning of a burning or a splitting sensation in the perineum or in the vulva. The second stage of labor is strongly influenced by maternal position. Lying flat on your back is the worst position to be in. I mean, I guess if you were doing a handstand I guess that could be worse. But basically, having a woman flat on her back is not using the wonderful effects of gravity and positioning that could be achieved if she were squatting or in other kinds of positions. Um, we put women in this terrible position in hospitals because it is convenient for us. It is much easier to do blood pressures. It's easier to do vaginal exams. It's easier to catch the baby when mom's on her back. The epidural that we've placed for her and our sakes made her numb, and so that's got her flat on her back. So the things that we do to put women in their supine position goes against all of our eons of birthing prior. It's much, much more helpful. The third stage of labor is the placental expulsion. It's the time between when the baby is born and then the placenta is delivered. So after the baby's born, the uterine cavity will become smaller. And when it does so, then the surface area isn't as great as it used to be, of course. And so that causes the placenta that used to be adhered to this large surface area to now not have as much surface area to be adhered to. And so the shrinking of the uterus will cause that separation or that pulling away of the placenta. Signs of the placenta separating is a gush of blood. Sometimes blood gets trapped behind the placenta and then is delivered suddenly before the placenta itself. The cord lengthening at the vaginal opening. The fundus may rise in the abdomen a bit as the placenta descends into the vagina. And the uterine shape will change from flat to firm and globular. This picture is a diagram of a nurse doing what she's supposed to do, which is to inspect the placenta to make sure it is intact and that there are no retained fragments left in the uterus, because that would be bad. Any retained fragments can prevent the uterus from contracting down all the way, and the woman could then hemorrhage. What you're looking at here is the Friedman curve. In 1955, OB doc named Friedman looked at 500 primips aged 20 and came up with a theory of what a normal labor should progress like in terms of time. The problem is, as I mentioned, he only used patients that were in one hospital, only 500 of them. They were all primips or primiparous. They were all around age 20. 96% of those were heavily sedated, and over 50% of them required forceps delivery. Okay, so you have a pretty uniform population that you're looking at. Well, the problem with this is he looked at just one type of client and then based this normal, supposedly normal process on this one type of client. But what about nowadays where we have older moms who are maybe multips and who aren't sedated and who don't have instrument-assisted births like forceps, okay? That would be a more robust source of information. So what happened was, so Dr. Friedman set up this curve in 1955 that all the OBGYNs used after that as a guideline for how each woman was progressing. And so if according to Friedman's curve, the woman was slower than she should be, the doctor might jump ahead and say, oh, well, she needs a C-section because she's not progressing fast enough. Okay, see what I'm saying? But in 2010, we looked at 62,000 labor records. So you're comparing 500 in 1955 to 62,000. labor records. In 19 hospitals, we looked at all kinds of different women and different labors, and we found out, in fact, women take longer, that the normal periods that Friedman thought are too short and that they don't fit everybody. And the problem with Friedman's curve is that the number one reason that women get C-sections is for a term called failure to progress. And that's all based on, this failure to progress is being based on that 1955 Friedman's curve. So in fact, the woman may be progressing absolutely normally. So in more modern times, we like to let women, as long as the baby is looking okay based on the fetal heart tracings and the mom is looking okay, then we like to let things progress naturally. And it's very common that, as I mentioned previously, that once the woman has reached full dilation, she may need to just breathe and rest and do some light pushes when she feels like it, but nothing strenuous. There is a time period that midwives identified where right before the serious urge to push, a woman just needs to relax and rest, and we call this laboring down. And so as we move away from using this Friedman's curve as the end-all be-all, we will hopefully see less cesarean sections for the purpose of failure to progress. As you look at this particular diagram, you can see it compares nulliparous versus multiparous. And the multiparous, of course, goes quickly, more quicker than the nulliparous or the primip. They take longer. And so you can see the differences between the two progress rates of the women. All right, so this diagram again is showing the important aspect of the nurse expecting for intactness of the placenta. In diagram A, which you're looking at, is the placenta's fetal side. It's called Schulze. It's the shiny side. And so that's the side that the baby would look at, for instance, in utero. B, photo B, is called Duncan. That's the Duncan side, and that's the maternal side. So what you're seeing there, that roughness, is because it used to be adhered to the inside wall of the uterus, and it had to separate or pull away, and so that's why it looks rougher. C shows a separating of the membranes, and D is showing the umbilical cord vessels. There should be 2 arteries and 1 vein. So normal labor, by definition, is characterized by consistent progression of uterine contractions, cervical dilation and effacement, and then fetal descent. The fetus is the most vulnerable partner of the maternal fetal pair, of course, because it's immature and it's totally reliant upon mom's status to physiologically support it. So it's the most vulnerable and it's the least mature. Normal fetal heart rate at term averages 110 to 160 beats per minute. And while labor time varies, amongst all women, according to that Friedman curve, what is accurate with that curve is that the multips do progress faster. Some conditions that are associated with fetal compromise include the heart rate being outside of that normal range I just told you about, any presence of meconium-stained amniotic fluid. So meconium is a thick and sticky poop, and babies poop when they're stressed. So if you see some amniotic fluid with meconium staining, or what we call meconium in it, that is an indicator of some potential fetal problems. Seeing cloudy, yellowish, or foul odor to amniotic fluid is ominous because that's not normal. It should be clear and mild, if any odor at all. Um, any excessive frequency or duration of contractions, that's going to be hard on the baby because there's not time for the uterus to relax so that that exchange of oxygen and waste products can occur. Other indicators would be incomplete uterine relaxation. Again, if the uterus is contracting so hard and so consistently that there's not time in between contractions and it doesn't relax, then that's impeding that exchange of blood flow to the uterus and placenta for the baby. Maternal hypotension is a problem because if you don't have enough blood pressure, then you're going to have poor perfusion to the placenta. Maternal hypertension is also a problem. Hypertension can cause vasospasm of the arteries that supply the placenta. And then maternal fever, and that's considered 38 degrees or higher. Things that we can do to promote placental function. Positioning. That is the most important and common measure to promote placental function. So we can put mom on her side, especially on her left side, and that will prevent that heavy gravid uterus from compressing the aorta and the inferior vena cava, and that will improve blood flow within mom and therefore blood flow to placenta. In terms of comforting measures, lighting, usually soft and indirect, is best and most soothing for mom. The temperature of the room typically needs to be kept on the cooler side because mom's metabolic rate is sky high at this point and she's working. She's working hard. It's called labor for a reason, and so she maybe needs a cooler temperature in the room. Cleanliness and mouth care. Her mouth might get dry from mouth breathing. She might need ice or popsicles. And cleanliness, you might need to change the sheets or the gown. Maybe she's sweaty, or she might have some bloody show on an underpad. So those things might need to be changed. Bladder, we don't want her to get uncomfortable. If she has a full bladder, then that's going to cause increased pain because you have a limited amount of space inside that woman's body, and so when you have this big heavy gravid uterus and fetus pressing on a full bladder, that's going to be uncomfortable, but it also is going to impede labor progress because the bladder is just in the way and it's preventing downward passage of the fetus. Positioning is important. We try, in theory, to prevent supine positioning, a woman flat on her back, because that's not using gravity. But we do see it all the time in the hospital for women who have had epidurals. Upright is very helpful because you got the flow of gravity. Squatting is very helpful. But obviously those things can't happen if the woman has an epidural in place that has removed all of her sensory and motor functions to her lower extremities. Providing encouragement is very important, reminding the woman that her body knows what to do, that she's getting excellent assistance from her partner, and that everyone's there to help her have a beautiful baby, that kind of thing, reminding her she can do it, helping her breathe if she needs to, providing pharmacologic and non-pharmacological relief. Laboring in a tub called hydrotherapy is very, very helpful for many women, and that can be accomplished either at a home birth or at St. Elizabeth's in Red Bluff. Mercy Hospital does not have labor tubs, and per the nurses, they don't want them. As a nurse, it of course takes more effort to help your patient in and out of tubs, to monitor them frequently while they're sitting in water, that kind of thing. And so while it's very, very beneficial for a patient, it is hard in a medicalized environment to provide the electronic monitoring and stuff that we do in hospital. These are just some pictures of different positions and techniques for promoting labor. The upper left hand is a woman with her partner vertical, which is perfect, and she's walking. Again, that will help. Even the woman in the rocking chair, she's sitting, so that's even more vertical. That's helping. In the middle pictures, you see women laying on their side. That's going to help improve placental blood flow. The beds, a lot of women like to sit up and lean against the head of the bed, like you see in the second middle hand picture. Being on all fours is very helpful, not only in terms of in labor, but in getting the baby into the right position. And also, if we have any concern of the baby lying on the umbilical cord and it getting pressed, which would prevent good flow of oxygen, then putting the woman on her hands and knees can help the baby drop off of that compressed cord. So that's what that picture is showing. Our beds fold and break away so that you can use some of the beds as arm rails to hang on to, like you see in the bottom left-hand corner. And even if the woman has to be on her back, at least you can see in the middle lower hand photo a woman who's almost in a squatting position with her legs drawn up and the head of the bed up. And so at least though she's somewhat supine, she is partly vertical and she does have gravity and a squatting position, which helps to open the diameter of the pelvis more fully. So nurses always have to be alert for signs of an impending birth. Always believe your patient. If the patient says the baby's coming, believe it. If the patient is grunting or you can see she's bearing down, check the perineum. Be prepared to catch the baby. In OB, we like to say that pizzas are delivered, babies are caught. So be prepared to catch the baby. In every OB department, there will be an emergency precip tray. Precip stands for precipitous. And a precipitous birth is one that's unusually short. So the labor is very, very short, usually 2 to 3 hours from the start of the delivery or start of labor to delivery. So that's a precipitous birth. And OB wards have practice precipitous birth drills. Just like you might have a practice code blue on MedSurg, in OB, we practice precipitous births because there may not be time for a medical provider or anesthesiologist or respiratory therapist to get there. And so you as the nurse are catching the baby. What we do is we locate the precip tray, and on that tray there should be basic things for the precipitous birth, like sterile gloves, gauze, things like that. And as nurses, we support the infant's head and their body with our sterile gloved hands. We maintain their airway and their temperature by drying the body off and putting the baby skin to skin after birth. And we also maintain the airway by suctioning mouth and nose. So we keep them dry, keep the airway patent, support head and body, and put babe on mom's chest. And by then, somebody should have arrived. That's a medical provider. The nurse's responsibilities during birth include preparing the sterile table, and different providers will have different requests for what's stocked on their table. As you get oriented to an OB ward, there will be provider lists, like let's say Dr. Jones wears size 7 sterile gloves, likes a certain size of suture, etc., etc. So their preferences are set up, and that's part of the labor nurse's job. When it gets close to time to deliver or catch the baby, then the sterile table is prepared and a sterile surgical drape is placed over it until the equipment there is needed by the physician or the midwife. We are responsible for cleansing the perineum, for doing the initial care and assessment of the newborn. At Mercy, there is a dedicated nurse called a transition nurse who is assigned at the start of each shift so that the mom can have her own nurse, and then when the baby is born, the baby has the transition baby nurse. We also are responsible for the administration of medication such as oxytocin, which is a medication that works like our hormone Pitocin and to contract the uterus and control blood loss. This is a diagram showing the zigzag pattern that we use to cleanse the perineum. You figure or number 1 on the upper left-hand diagram shows from the clitoris out to the lower abdomen. 2 and 3 are zigzag from the labia majora out to the inner thigh. 4 and 5 are a single stroke over each side of the labia and perineum. And 6 is a single stroke down the middle over the vulva and perineum. Then in the upper middle picture, it shows gentle pressure on the perineum with one hand, while there is counter pressure on the head to decrease a fast descent. And then on the right hand upper picture, it's showing the wiping of the face and suctioning of the nose and the mouth to get the wiping of the face with the cloth was so that you can get a better grip because the baby is very slippery. And then as soon as possible, as soon as the nose and mouth are cleared, then they're suctioned before the baby is fully born. So it's done at that point. In the lower left-hand picture, the provider is feeling for a cord, and if it is wrapped around the neck, then it is loosened and taken off from around the neck. Then in the middle bottom picture, there's gentle traction on the head to the anterior part to allow the shoulders to pass under that symphysis pubis. And then finally, in the last picture on the lower right, the provider is kind of lifting the head and allowing the passage of the posterior shoulder. Okay. These are photographs of the whole process. You can see, as I mentioned, in the previous slide, that the descent is kind of slowed by counter traction. In the middle upper picture, you see a blue sterile cloth that's the provider is holding with one hand because the baby is slippery. And then the upper right hand, you can see a long suction line with a suction catheter so that they're using that to suction baby's mouth and nose airway. And anyway, all these pictures are the whole process, as I mentioned, and ends in the lower right-hand corner with expulsion of the placenta. And the placenta should not be, the cord should not ever be pulled aggressively because that can be very dangerous. It can cause an inversion of the uterus. So the uterus and the placenta don't separate, and by pulling on the cord, you have caused a prolapse or pulled out the uterus, which is very life-threatening. Responsibilities of the nurse after the birth of the baby is, again, at Mercy, there will be a transition nurse to help care for that baby, to promote normal respirations, maybe stimulate it to make it breathe, support its thermoregulation by drying it and putting a cap on its head, identifying the infant. There's usually 2 identifiers on the baby. It's arm or wrist and an ankle, one on mom, one on dad. And then we have to care for the mom. And so the mom's nurse is observing for hemorrhage, checking vital signs, usually Q15 times 1 hour, Q30 to 60 minutes after that first hour. They're checking not only the vital signs, but the fundus, making sure that the uterus is clamping down and contracting so that the mom doesn't bleed out, making sure that the bladder is empty. If the woman has a Foley catheter, making sure that it's patent and draining, checking for any bleeding discharge, which we call lochia, and the maximum bleeding discharge should be 1 peripad per hour. The fundus itself should be firm, it should be midline, and either at or just slightly below the umbilicus. We have to massage that fundus if it is boggy or soft. And one of the best things we can do is put the infant to nurse immediately, because the oxytocin release will stimulate contractions and help to firm up that uterus. The other things we do is promote parent-infant attachment, and part of that is by doing what we can while the baby is on mom's chest and baby and mom are looking at each other, and baby might be looking for a nipple, maybe not, but at least skin to skin. And there's a number of things that we can do while the baby's on mom's chest. We can continue to, dry it off and so forth. Part of what we do is promote attachment. We like to know what parents' desires are. We try to encourage skin to skin as much as possible for the first hour. We recommend early breastfeeding because, again, that will not only establish a bond and an attachment, but it has the side effect of helping the woman's uterus to contract and get back down to a normal size so that she doesn't hemorrhage. Recommendations are to use that first hour, golden hour, to establish breastfeeding, and visitors should be limited. It is an exciting time. Everybody wants to take pictures and so forth and so on, but we as nurses need to try to be gatekeepers and help manage that if at all possible. This is a picture of the baby nurse or the transition nurse banding the newborn. Okay, and then the rest of this presentation is just, yes, it's just questions. There are 4 questions, and the answers are on subsequent slides. So I'll let you review those on your own. I know this is a very big chapter. Spend a good amount of time on it. As I mentioned before, there are 3 or 4 chapters throughout OB that are the most important, that are foundational information that you need to know, and this is one of those chapters.